previously the medical director for behavioral health in the Health and Hospitals Corporation of the City of New York, which operates 11 public hospitals in New York City. He served as the Chief of Psychiatry at Bellevue Hospital and has led large delivery systems and policy. And he was previously Associate Professor in the Department of Psychiatry at New York University School of Medicine and founding director of the NYU program. He received his PhD and MPH degrees from Harvard and his BA and MD from Brown University. And he is leading the NYCThrive movement. It's an incredible organization, and they're doing actually a lot of global work and statewide and US work. So I'm excited to have him share more about what their project is doing and how they're changing mental health in cities.
Yes, all right.
Excellent. Good to see you.
I'm as surprised as anyone that worked. That's great. So first of all, I want to thank you for pulling all this together and your incredible patience with Zoom naive folks like me. But here we are, so it's fabulous. I'm very happy to be here. So, you know, I just love the framing of the Agora. This idea of this ancient idea of a public space where commerce happens, where people assemble for important things and interact, and it's a whole different way of casting mental health work than we have, and I feel like we really are in a new wave of a global mental health movement that takes that as its assumption that everybody not just has to be as the table, but is needed as a co-owner and co-creator of the solutions and the changes that we make to improve mental health and to get to happiness. So that is a bit of a spirit that and perspective that we really tried to bring to what has been called Thrive NYC, that I'm going to talk a bit about, taken from the perspective of a city government, of a local government. What are the ways that we touch systems and people that can indeed create an agora for mental health that really brings more of city government, more of communities into solutions, and where we can fill in gaps that have been harder for people to fill. Where's our sweet spot, as well as bring all of government and our work with our communities to this task. So that was the intention of Thrive. It's a first step. It's still young. We're still getting our legs, but that is, I think, a real driving framing of it. And so the picture you have in front of you, I hope that's in front of you, is when we launched the report that laid out what we expected to do. This is a little over 3 years ago. Most of the initiatives were only on paper. The last couple of years have been really standing them up and setting them in motion. But you see this array, and you only see a very small segment of the crowd standing behind the First Lady, who's really been the spearhead of this, First Lady of New York City, Chirlane McCray. You've got the mayor there, their children, and just a sea of commissioners and deputy commissioners of all sorts of city agencies, from the police department to the health department. You have federal, state, local elected officials, commissioners of agencies, as I mentioned, CEOs of large human service agencies, presidents of universities, advocates, peers, all for a mental health plan. And I just never thought I would see that kind of traction and buy-in and enthusiasm for a mental health plan. I think part of why we got that assemblage and why we've brought in that wide net is because we framed the issue of mental health honestly, that we framed it in its fullness. This was something that affects all New Yorkers in one way or another, either who you know or who you live with. That mental illness is diagnosable in 1 out of every 5 New Yorkers. This affects our schools, our workplaces, our neighborhoods, our jails and prisons. And so we have to act like it. We have to act in that fullness of the problem with a fullness of response. So all these people who showed up see themselves in this issue and see themselves in this vision. And I think that itself was a real sea change in how the city saw its connection to mental health. But living up to that sort of vision, like where do you start, was our first bit of business. So we spent actually, about 10 months before that picture, going around the city, doing focus groups, talking with over 200 organizations, not just the usual suspects that have always been involved and at the lead of mental health work, but we talked to other parts of the healthcare system, other neighborhood action groups and human service organizations and clergy and people working on economic development and city agencies, because all of them touch this issue. Few of them have been reached out to as part of the solution to these issues. And so we listened to them all and came up with a strategy for action that started with what I'm showing you here, which are our 6 key principles. So these principles of action really laid the directions that the city thought, these are the new ways we should lead others to go into, either by really closing some things, putting in solutions, or leading the way to the kinds of solutions we need more of and spark the imagination of others to go in those directions also. And so they are briefly to change the culture, to act early, to close treatment gaps, partner with communities, use data better, and position government to lead. Those are our key flags for movement. And all the initiatives that we launched at that event each come from or derive from the intentions of these key principles. So just give you a flavor of the size and reach of this thing. Change the culture describes changing the culture, changing attitudes, bias, etc. So that includes a goal to train 250,000 New Yorkers in mental health first aid, but also meant signing on to changing some deep cultures, how we police. So training all of our patrol officers in NYPD and crisis intervention training. Really working on school climate and how discipline works and is more mental health and trauma informed. So that's a big sway of work. Acting early, we looked at, okay, what are some priority investments that we could get the ball rolling on as a city, not be the last word, but really change the dynamic around investments in mental health prevention and early intervention. And so this includes things like a lot of work with schools, because that's what the city touches, our public school system, reaching youth, giving every school campus, there are 1,800 of them, either a mental health clinic or what we call a mental health consultant, as a resource to principals to do needs assessments in their schools and identify resources that they could connect to. A commitment to scale up in our public pre-K and daycare centers, socio-emotional learning skills and caregivers, and creating an early childhood mental health network that serves those settings to coach staff and parents, especially to reach kids in our public systems who have outsized exposure, unfortunately, to early childhood adversity and trauma. Close treatment gaps. There were a lot of gaps we wanted to close, but we prioritized a few to start with. Using the convening power of the city, we have a learning collaborative across almost 30 hospitals to try to universalize screening and treatment for maternal depression, for example. Partner with communities. We need to see communities as the incubators of mental health that they are, and the sources of real wisdom for solutions to do better. So that includes efforts like learning collaboratives with a range of community stakeholders to solve problems that they identify as priorities. Using data better, to do all this kind of work, this expansive agenda, to do what I hope you hear as a common thread of these initiatives, which is to put more of the work and skills and ownership outside of the conventional mental health system, in our communities, in our churches, in our daycare centers. That kind of approach, in our schools, that kind of approach needs a different approach to data, to see where the issues are, see where the gaps are, and see more real time where our impacts are. And then finally, position government to lead. You need government to lead a strategy like this. The treatment system can't do it, although you need them. Insurance companies can't do it, though you need them. You really need government to lead. And for government to lead a strategy like this, government has to change. and build its own skill sets and organize in a way that can work across these agencies and brings in new kinds of perspectives as a new habit of doing mental health policy. So that is a kind of very brief thumbnail tour. There are about 54 initiatives. I don't know how I mentioned, maybe a handful, but you know, multiply that kind of ambition and reach across 54, and that's what you got as our down payment on moving along these six ways. I'm happy to drill down in what we did in these different buckets of principle-driven work after I talk, but that gives you a flavor. I do want to emphasize, though, two kinds of things that we did, which I mentioned briefly, but I just want to drill down a bit, that speak to this issue that we're increasingly finding out, and other cities and localities that have reached out to us. About 200 mayors in the US that have signed on to something called the Cities Thrive Coalition, trying to pick up this excitement about what can local government-driven change look like, and several other cities that have picked up the brand, Thrive London, Thrive Bristol, other Thrive cities in the pipeline, coming to the table. We're not pulling them to the table, they're reaching out to us. And one commonality we're seeing is this turn to the community, the turn to the neighborhood, that if we're gonna, and we built a lot of programs that have citywide reach, but increasingly appreciating that they need to land and feel owned and show impact at a neighborhood level with neighborhood partners. The maps you have in front of you are maps that we use a lot in our public health work. Start at the top right, rates of lifetime depression in the population. The darker, the greater the prevalence. Lower right, psychiatric hospitalization rates. Again, the darker, the greater likelihood of being hospitalized. But then you move to the left, lower left, and that's life expectancy. Greater density is the worse life expectancy. And then the above right is the rate of people who've been in jail, people on parole or probation. And so you're seeing, sadly, these maps are very similar. Similar densities of overlaps, as too many of us know too well, of these very close intertwined connections between social determinants and mental illness and poor mental health, and I include substance use whenever I use those phrases. These things interrelate. This also shows great segregation by race and effects of histories of structural racism. So it just shows the complexity of the connections between our social world and these outcomes that we're caring about, both as drivers of worsening these social outcomes and social outcomes that in turn worsen mental health results in a vicious circle. And if we're going to break that circle, if we're going to break that cycle, we not only need the sort of comprehensive scope that I laid out through our principles of action, but in how we execute and implement that scope. And so there are two ideas that we're getting the hang of doing better that really thread through a lot of those principles. And it's great that this is a global event today, because we learned so much from other parts of the world in doing something called task shifting or task sharing, one of those threads that really goes through a lot of our initiatives. And basically, this is an idea that really grew out of work that I did and other people much more prominent before me and that are you'll hear from today or have heard from today that challenged who you need to be to do mental health work. That a lot of the skills and steps in doing evidence-based treatments and counseling and prevention interventions can be done by non-specialized people, by fellow citizens, by peers, by parents, by teachers. And so we should give them those skills and spread the net and extend the reach of the mental health system that way by bringing them in as full partners. There's a great recent meta-analysis of a lot of this work in the top left-hand, the reference by Singla and colleagues, and really also quarterbacked by Vikram Patel, who I believe either appeared or is about to appear today. Dixon Chibanda, also an Agora member, really brought this work to just a fascinatingly simple and incredibly compelling idea called the friendship benches, which trained originally grandmothers in Zimbabwe in problem-solving therapy to be outside of primary care practices, which was an option, often a much better user-friendly, compelling, credible option for people to use as their gateway or ongoing source of care that showed really good results. These were published in JAMA. This notion of task sharing, I found only really done in a serious way before we started to see how we could do it in New York in an effort called CPIC, or Community Partners in Care in Los Angeles, with Ken Wells and his colleagues, where they had a network of 100 community partners, from barbers to park staff to providers, each trained in certain degrees of skills that they felt they could manage to create a whole community net that captured and supported people with depression. So we borrowed shamelessly from all of these, from Dixon and his group in Zimbabwe. We used their training manual and created what you see on the bottom right, our Thrive friendship benches, which we do in a bit of a more pop-up way. We've go to neighborhoods of high need or where events happen that may be have rattled communities. We've had, I think, over 80,000 contacts so far with this, but it's really a powerful approach to get deeper into communities and create a much larger line of who is involved in the work. Another effort at task shifting or task sharing that we did through Thrive was something called Connections to Care, where we gave seed grants to partnerships of behavioral health providers and community-based organizations, 15 partnerships spread across a lot of those same parts of the map that you saw earlier, where the role of the behavioral health provider is not just to see people that are identified who really need specialized care in these places being job training programs, shelters, daycare providers, youth, after-school youth and disconnected youth programs. But to not only be a provider of resort to them, but also to be a coach and mentor and skill builder, a real partner in that way to these community-based organizations. And so far, through these partnerships, over 1,500 of these community-based organization-based staff have been trained in evidence-based practices like motivational interviewing and using standard symptom screens. And that's resulted in 14,000 screenings, referrals, about a third of those being identified with signs of diagnosable mental illness. So it's really been, again, an example of how this deeper chain of collaborations that get into communities at a whole new level can really reshape how people are reached and helped. Connections to Care, this gives you a sense of how their referrals really increased. And these were often people who had not been connected to the system before. And we surpassed our goal that those referred would actually get connected. Rates of over, in the most recent reporting, 70 to 80%, which is, if you're familiar with referral retention rates in mental health in the US, that is extraordinary. And so we think this community way to go is the way to go. Task sharing is really something we want to learn how to explode and make the new normal here in New York City. The second big idea, so task sharing is one big idea that really threads a lot of the initiatives and makes them get deeper roots. The other is that I also alluded to is that bringing in more of government, bringing in more sectors, bringing in more agencies to lead and own this work. These are just a sampling of the city agencies, including our public university, that where those some of those 54 initial initiatives resided. This was not just the health department. This was, just not the usual suspect leaders. This was really shared across the board, and it's starting to not only succeed in terms of these initial initiatives up and running. But a lot of these agencies are now owning the work in a new way and really looking to how it becomes more embedded in their respective missions. And I just want to close and then hear what others think or ask or have to say. But a lot of this stuff came with a lot of money. New York City was able to really invest to to take a stab at starting to make an impact. And again, this is early years for this work. But to start to make an investment that could have the reach of a city as large as ours. But a lot of the interventions were pretty low cost and really depended on the convening power of the city and local government, that it's used to bringing together multiple sectors, that it knows its neighborhoods, that it has this position to move a strategy like this even with limited resources. And as we work with other cities, we really emphasized the principles are ways for you to do what you can do. But those are the directions we think you can really make a change and kind of change the game. One of our initiatives that's an example of this is that I mentioned was what we call the Maternal Depression Learning Collaborative, where we brought together these dozens of hospitals with a shared goal to universalize screening and connection to treatment for pre and postpartum depression, which we know if you're going to pick a public mental health sweet spot, that's one of the ones we picked. That and early intervention with kids for resilience and so on. This pays dividends for not just the mother, but their children for life. And so we see here the rising, success rates and percent of women screened pre and postpartum in the clinics that were part of these hospitals. And the value just of convening and giving people a method to innovate and drive their own work through quality improvement methods results in this kind of activity. So again, we're early. We're mostly been looking at data that tells us that we're running the way we wanted to, that we're reaching more people than had been before, and as intended, we're starting to get the kind of impact information and results information, but that's really our next phase as these things mature and hopefully connect and echo and resonate with each other and drive more people. And this is really key. This isn't the last word. This really shows other directions to go and that others pick up and follow. Other large provider systems, our payment systems. That's our hope, that we can get enough traction to move others and more momentum. But I think this notion, this Agora notion, that it takes all of us and we have to create the ways that all of us participate and drive the change, has really brought in other cities. I mentioned the Cities Thrive Coalition that formed as just a result of interest and being motivated for cities to lead and a really untapped area of government to lead. Thrive Bristol was launched in the UK, Thrive London, as I mentioned, something called the International City and Urban Regional Collaborative, which is a global group that really tries to bring city government and build leadership capacity and a kind of a peer group of best practice sharing, has adopted our 6 principles. So we're excited to see the kind of animated and exciting change that just stepping up and saying, hey, we should take this on. This should be central to what cities do and care about and are held accountable to deliver on. Getting some resonance and some spread. So thanks for your attention, and really curious to hear other thoughts and answer any questions.
Yeah, wonderful. Thank you so much. We weren't taking questions today just because we know the timing is tight, right. So we didn't. But
I know you may have questions.
I do. Yeah, so just, so you're kind of creating a blueprint for governments to really tackle mental health within cities. Is that kind of, a good kind of synopsis
Yes.
and then addressing it. Yeah, so that's so great. So other cities can sign up to be a part through the city's Thrive. Is that like how does the general population help drive this in government or bring it to government and say, we need you to take this on in our city?
Yeah, so that's really a great question. And what we're finding is these other, kind of self-named Thrive cities and other cities. We don't we don't push the brand.
Yeah.
But the cities that have really said, hey, we're really interested in what you're doing, have taken different roads into how they, bring the public voice in. For example, Thrive London really started at a neighborhood level, kind of what we would call town halls, local meetings. What should we do? What are our priority needs? And then those kind of bubbled up into identifying commonalities across the city. We started really thinking more citywide, and are now looking, okay, how do we make this, how do we have this be applied to show local impact and improvement? And so to me, it's really just not necessarily what we've done, but what we are all collectively learning by seizing the idea that cities and local government should lead, because they're uniquely in that position to bring across cross-sector work, but also to stay true and honest and ultimately accountable to their neighborhoods. So it's a real important sweet spot for this kind of approach to mental health. That in the U.S. at least, usually it's federal and state governments that have held the bag on mental health and the dollars for it and the authority over it. That hasn't brought us to where we need to be.
Yeah, interesting. Yeah, I mean, I really want to commend you on the work too that you're doing from a preventative standpoint, because often that's kind of the last thing that people, they look at the crisis and the emergency and whoever is the loudest. And so there's so much that we can do in the prevention space, and especially as it relates to women and postpartum depression, and because we know that impacts the mental health of the child, the children. So yeah, I'm really grateful for your kind of leadership, and then bringing city leadership into it, because we know that's also what has such a big impact on stigma that maybe we don't necessarily feel immediately, but in 10 years from now, I think we're going to look back and see this period to me as a big turning point from what I've seen in the space. So as you look and you've had a lot of experience in mental health, and you look at the past and what's happened and where we're moving in the future, what do you feel kind of most hopeful about?
I feel a real sea change. Thrive started, our initial ambition was to write a report, lay out a vision of a public health approach to mental health. And when the First Lady announced that, she was asking the health department to do that, the pull we got, we didn't have to push this. We were pulled forward by interest, by demand, by the energy, and the content of the focus grouping that we did, of people coming to town halls we held, of the real. I've been at this, as you mentioned, for a while, and this was new. So I really feel that these issues are just, we opened a lid. I mean, I think that was a big contribution of the leadership here, is they just said, this is something that's our business now. And I think that just opened up a lot of pent up frustration, a lot of pent up sadness in people's lives, and in looking at their communities, of things that just weren't getting hearing. And now it's, like, why haven't you fixed it yet? There's still this problem. There's still these people there. And I'd rather have that expectation. I mean, who knew that city council members would care about whether mothers have actually gotten better from the screening that they got? To me, that's a good problem to have to be accountable to and answer to. as you know, these public health initiatives and something as, is broadly scoped with a lot of intersecting parts that have to come together for the outcomes we all want, isn't going to come in a year or two. But that's now a part of the, expectation and the dialogue, I think is itself an accomplishment.
That's wonderful. Well, thank you so much. It was great to see you. And I know how busy you are, so it's wonderful that you took the time out and helped share the work you're doing. And hopefully we can encourage other cities around the world to take it on too and make it a priority, especially in government.
We're always happy to talk and to learn to any place. So call us.
Yes, thank you.
All right. Take it easy.
All right, you too.